this, we'll go to the panel discussion straight. I invite Professor Ashok Das sir, and also Dr. Mukulesh Gupta, Dr. MP Barua, Dr. Bijay Vishwanathan, and Dr. Abhay Shahu. And first, we'll take up the questions with Dr. Bijay Vishwanathan because he has a quick session and he'll be leaving soon. So, to start with, we'll take questions related to semaglutide. And the first one that we have received is why oral sema is held as a game changer and a life changer.
As I told you, Jayant, I think so far we never knew that peptides can be given orally. And I have used liraglutide for the last decade or so, and I've been very impressed with GLP-1 receptor injectable liraglutide and dulaglutide. But when I say a tablet, patients are very happy because patients are not happy injecting themselves with insulin and with another injection of liraglutide. Therefore, it's a game changer because it's a tablet.
Yeah, very true. That's why we tell it, and it's used.
And also, Jayant is also a lifesaver because, as Vijay beautifully described, it has a proletaurian effect on the cardio, renal, obesity, NASH, neurological benefit is to be shown. So, I mean, it's a proletaurian effect, pleiotropic effect beyond description, which comes through oral. And the quantum of change also, Vijay, if I may say, is quite heavy. No, the amount of weight loss. You see, amount of weight loss. The American press said is a sunshine drug because the weight loss was almost about some places 25 kg in experimental. So it's a both, as Vijay said, game changer, life changer because it affects all the aspects of diabetic comorbidity. Am I correct, Vijay?
Yeah, absolutely, sir.
Very true, sir. Very true.
Very true, sir.
But the question comes to mind: can we apply this protein in a pill concept for developing oral insulin?
Yeah, I think so. That's up to Novo Nordisk to do it. So we are only clinicians. So I think if this can work, if it can work for semaglutide, why not add SNAC to?
I think very beautiful.
I'll add something. Actually, oral insulin is already there. Oralin is there. Actually, they have tried, but still they were not successful to do that. But still, I don't know because there was in between. There is Apriza was there, inhalation insulin. Then oralin came, this oral insulin, and but still they have not yet succeeded to reach the target.
But before that, the GIP also has taken the same route, and today we have a GIP analog modulation, Jayant, and of course Vijay must have spoken about it. I missed one or two slides. The tirzepatide. It is even more effective than semaglutide. Am I correct, Abhay? In the India trial. So I think Jayant, you are correct. It will be applied more and more to many of the proteins, starting with tirzepatide and other things which are undergoing trial. And as Vijay put it, it will be the pharma which will be putting it in the laboratory and giving it to us. But the future is very bright.
Yeah, Dr. Barua I want to take an opinion of Dr. Barua. Yeah.
Actually,
Manas is here. Manas.
Yeah. Novo could have made oral insulin a decade or 2 decades back. But then the bioavailability is not that good, and the cost is going to be very high because we have to supply huge quantity of the crystals orally, which is by injectable you need to only inject a few units. So I think that's one reason. And you cannot have a very long-acting insulin orally, but probably you can only supplement the short-acting part of prandial part as of now.
Yeah. So let us move to next question. We have a question from Dr. M.R. Behera. The weight-reducing effect of the semaglutide, can it be independent of glycemic control? Is it recommended for non-diabetic weight reduction?
Yeah. So, Jayant, off the record, people have been taking in India liraglutide, though it's not approved by the CGI. They have been taking in people without even pre-diabetes. This is off the record, so it should not be recorded. So people are using liraglutide, and I'm sure oral semaglutide also will be used by the same people to reduce obesity. It's approved in the United States, but not in India. So
yeah. So we have a question: the glycemic and the extra glycemic effects of semaglutide. Can you summarize again for our listeners?
yeah, because as I said, it works on 6 out of 8 octet mechanisms. So I showed you a picture of the liver, muscle, kidney, brain. So it works on multiple sites. So it's going to be a wonderful drug because we know GLP-1 receptor injections work very well. And now we have a tablet form, which is as good as liraglutide.
Perfect. The last question will be, what are the ongoing trials in oral semaglutide after the launching is ready?
So as I said, there is something called SOUL study going on, looking at cardiovascular benefit. So only then you can say this is as good as SGLT2 inhibitor. Then I think there's a study called FLOW study, which is happening in patients with CKD. And then there is some focus study where retinopathy has been a little concern in one of the SUSTAIN studies. SUSTAIN was the injectable semaglutide. And SUSTAIN 6 showed some progression of the retinopathy, especially proliferative retinopathy and maculopathy. Therefore, there is this study called FOCUS study, which is looking at proliferative retinopathy and non-proliferative retinopathy. So all these are studies which are going to come in the next year. So till that time, don't use it in people who have retinopathy.
Yeah, very right. So thank you, Bija. You have done a wonderful job. The message was very clear. And I request Professor Das to just conclude this incretin part, because I think the session is the diving deep into insulin and incretin. So we can.
I think, Jayant, as you rightly said, and Bijay very beautifully put, that is Bijay's. I think let us be a little relaxed. Bijay's trait. You know, he speaks few words but conveys everything, and very cool. He is Mr. Cool. I mean, you know, beautifully he has put everything together. I particularly believe that oral semaglutide will stand out as the molecule of the decade for 2 reasons. The price is one thing which will not discuss it here, because, you know, that will come down as the use increases and the more drugs are prescribed, or we have other people to support the drug, like the agencies, like the reimbursing agencies, all that. That is a different story. But if in a single pill, Jayant, just see, oral pill, you can achieve a great deal of weight reduction, cardiovascular, renal benefit, and the flow and shoal, both so prospective data, as Bijay rightly put it, a lot of kidney benefit. It is also a drug to be used for the people who have dementia complex, whether Alzheimer's, non-Alzheimer dementia complex. It has been used it's a pleiotropic effect. So I think this incretin invention is really innovation. So only when invention is with value, we call it we call it innovation. So it's an invention with a great value. But Bijay, thank you very much. Thank you very, very much.
Thank you for joining us. Thank you for making it so simple. Thank you, Bijay.
Thank you, Dr. Kanungo. Yeah.
Thank you.
So we'll go to the insulin part, and we are getting very simple questions for the beginners, and I think we'll start from Dr. Manesh. And the first question is the indications of short-term insulin therapy. We have to redefine for the benefit of our listeners.
Yeah.
And Dr. Abhay Sahu is with us.
Firstly, refer to one of the articles published not recently, in 2009. Professor Ashok Das sir is there. It was in JAPI, although it was published in favor of premixed insulin, the first premixed guideline in the world. But it actually tells you what are the indications for your usual common practice, diabetology practice. You can say that for short-term insulin, if you ask me where do I use it, say, for example, patient is going for surgery, patient is going for pregnancy. Pregnancy can compare to the whole lifetime of the patient is about 9 months, so you can short to medium term. And also, patient comes to you with high HbA1c at the very beginning, initial part of diabetes with glucotoxicity. HbA1c is pretty high, patient is drug high. There also we use insulin. Okay. Most we use basal insulin because people do not want to go for premix insulin, which of course at times require 2 doses. But with the advent of newer co-formulation, which was discussed today already in this session, it's probably that is one of the options for using as a short-term for avoiding glucotoxicity. And then, of course, if the patient choice is there, at any point of time, you can use it. And for patients having diabetes for a pretty long period, of course, that cannot be short-term. Then in that case, you have to be prepared for a maybe lifelong therapy of insulin. But the other instances which I have already mentioned, there can be good cases of short-term initiation.
Very, very nice, very appropriately described, and I think this part of the discussion is very clear for the listeners.
Can I say
Professor Das,
Manas is voracious reader. Manas referred to my paper. I think I'll send you the copy of the continuation of the paper, Manas, where we also discuss. Manas, are you here? Manas? Yeah. Manas, we just also discussed one concept which Professor B.K. Sahai, my senior from Hyderabad, Rakesh's father, Professor Sheshaya, and many others had given. Also from the Japan, that concept had come, that if you give a short-term insulin in type 2 diabetic, you know it better than me, young type 2 diabetic who had got very short history, if you give short-term insulin for between 2 and 4 weeks, we can have a prolonged honeymoon. You are young people, all of you must be having honeymoon for about 25 years. But here honeymoon can extend not only 2 to 3 to 4 months, it can be up to 2 years. So in the early on, if you give short-term insulin therapy for 2 to 4 weeks, Manas, I'm repeating 2 to 4 weeks, I reviewed the literature in that paper, you can find a free period from diabetes for about a couple of years. So that is also one use, which I'll send that paper to you.
Yeah, there's an extension of metabolic memory, which
exactly.
Last decade.
Yeah.
These simple works are at times very informative and valuable, and that is very useful, especially for the beginners.
So now, Jayant, I'm giving to any young onset type 2 diabetes, even for the ones who were cured of the COVID, were getting insulin at the time of COVID and steroids. I'm continuing insulin for remaining part of the diabetes therapy for a long time. I'll pass on the data to you because it's worthwhile seeing whether this short-term diabetes gets totally cured by insulin.
Yeah, very nice, sir. This is what we need to pass on to the younger generation. And another simple question has come. I want to start. When should we start insulin type 2 diabetes? Because our undergraduate curriculum and the postgraduate curriculum doesn't have clarity in approaching a case of type 2 diabetes. So if I'm a fresh medical graduate, you have to guide me regarding initiation of insulin therapy in type 2 diabetes.
So, correct. So I think if you go by the conventional approach, most common scenario is OAD failure, which is defined as continuous 6 months use of adequate dose of sulfonylurea drugs, and you're not getting good results. And you can extend that to other OADs which are available in the armamentarium. Then, of course, it is good time to go for insulin. And of course, if you go by the HbA1c criteria, it is well accepted that more than 9.5 or 10 HbA1c, it is better to start insulin and continue it till the blood glucose is stabilized or sufficiently low, like in the range of 7.5 or 8, where you can try oral tablets. And third condition is any acute metabolic complication, you straightway start with insulin, like hypersmolar coma or diabetic ketoacidosis. And you have to be very careful while withdrawing insulin in such patients. And patients with type 2 diabetes who have recently lost a lot of weight, who are metabolically compromised, or they are not very stable, they're in a catabolic state. Of course, even without looking at their blood glucose, even without looking at their HbA1c, you should start insulin. Allow the patient to gain some weight and become metabolically stable, and then only think about withdrawing insulin. And of course, in any scenario where patient is having moderate to severe infection of any kind, it is always safer to start insulin, and then of course think about converting to OAD if the patient is suitable. And finally, patient sometimes may present to it advanced complications. In India, you may get serum creatinine of 2 or eGFR of 35 at the presentation. And in that patient, probably it is always better to start, in my opinion, start with insulin rather than other drugs, because it's already too late in terms of the long-term complication development in diabetes mellitus. So I think these are the few scenarios I'm giving, but it's always patient-specific, and you have to take an individualized case-based thing, approach. And
you have completed the list. Manas, you have completed the list and nicely have simplified the indications in insulin in type 2 diabetes. We'll go to Dr. Muklesh Gupta. Sir, I'll ask you challenges in India for insulin initiation and intensification. We have seen our patient, when we talk of insulin, becomes very reluctant. It takes long to convince. The inertia is very high at all levels. At the patient's level, at the physician's level, at the caregiver level. So what are the different challenges we face and you come across in your daily practice?
Exactly. It's a very pertinent and a very practical question, because we want to initiate injectable therapy. Specifically, we talk of insulin in many of the patients, but we're faced with a lot of challenges. And these challenges, they are at the level of the patient and they are at the level of the physician both. At the level of the physician, if I talk of, then the most relevant is the time. Because the moment you need to talk about injectable therapy or insulin, you need time to convince, to talk to the patient, to understand his views, and to give knowledge about the advantages of the insulin, whatsoever they are, and to educate the patient on this line that now this is something which is important for that individual. You need at least 20 to 25 minutes before all these things, they can be transmitted, or you can say explained to the patient. Then if you talk of the patient-related issues, inertia issues, then it is the injection per se. Number one, myths around insulin, dependence, maybe the end of the world, maybe the thinking of the patient that this is probably the last thing which can happen to him. Then interference in his day-to-day life, maybe the challenge of injecting in public. There are many other factors. Then the cost. All these things, they will come to the mind of the patient. There are certain common factors like the risk of hypoglycemia, the risk of weight gain. These are common to both the aspects, whether it's the physician or the patient as such. So these are the limiting factors. But to me, probably, all these can be broken nicely. They can be really convert a bad sort of notion in the patient about insulin to a good one, if suppose we can spend that 20 to 25 minutes. And this is what is the average time which I think is really required for converting or starting insulin in any person for the first time in his life.
Very, very rightly told, Dr. Muklesh. It's first we have to break the inertia in the physician's mind and have to spend little time to overcome and tell him in the long term what are the benefits we are going to get. So you have discussed all the issues related to initiation and intensification, also told the solutions. Now we have received few blanket questions. I'll start from Dr. Abhay Shah. Professor Shah, are you here?
Yes.
Yeah. So the question is which insulin and which device? When you are asking, suppose we are going for insulin in a type 2 diabetes patient, which insulin and which device? So what is your answer to this?
So first thing is, when we are discussing about which insulin, probably for me, all insulin are same. Whether you go the previous insulin, normal human insulin, then subsequently the second generation, like you can tell this Novomix or Humalog mix. Then the newest one, you can think about Ryzodec. For me, blood glucose control point of view, all are same. But vis-a-vis to tell that, when I am telling about Novomix or Ryzodec or Humalog mix, these are the certain insulins. If you compare with our first generation human insulins, probably the risk of hypoglycemia is significantly less with these insulins. And of course, again, if you think about these newer insulins, of course, the amount of weight gain is also less in comparison to the old generation insulins. So if you think about the advantage, probably number of hypoglycemia will be less with particularly specifically Novomix and Humalog in comparison to particularly this normal human actrapid or human insulin or whatever the insulin will tell. Again, if we compare this Novomix and Humalog in comparison to specifically this Rajode group or the newer group of medicines, then again, there is further reduction in hypoglycemia with use of this Rajode group of insulins. That means as with successive generations, as the insulin, everything is getting changed, the dynamics is getting changed, the PKPD data is getting changed. So that leads to actually significantly less hypoglycemia. Again, the risk of weight gain will be significantly less. So this is the way how we can tell what sort of insulin one can take. And again, when you are planning for insulin, then you have to discuss with the patient what is the financial status, what sort of patient can continue, and whether patient can go for this newer generation insulin or not, because financial part is one of the important factors before deciding what sort of insulin you are planning. So from the efficacy point of view, all are same. But of course, these newer insulins have the advantage of less number of hypoglycemia, overall hypoglycemia, nocturnal hypoglycemia, and also there is less weight gain in comparison to the older generation insulins. Fasting. Then coming when you are thinking about device, again, with particularly with successive generations, the device has also significantly improved. You see, when we were using the previous devices, whether it is Novopen 4 or particularly this Humapen, in comparison to this, when you will see this now, whatever we are getting the Flex Touch, you just see what are the force what we are applying before giving the insulin. So probably in this Flex Touch or this whatever the newer devices, probably the force is significantly less, and also this smoothness or smooth going up insulin is almost a painless thing for the patient. Also, patient did not get any sort of convenience point of view that is good for the patient. So if you think about the pain point of view, of course, this newer generation pen is far superior than this older generation pen. But again, before deciding what sort of pen someone can give, we have to think about what sort of insulin we are prescribing. Because if you are planning for a human actrapid or mixture, probably this older generation pen is suffice. But again, this newer generation pen, which is already a pre-filled pen, or you are going for cartridge, probably this newer generation pen will be far better for those group of patients.
Very right, Professor Sahu. You have touched upon all the generations of insulin and device, and then it's all according to the affordability and the availability at the place we can choose and advise our patients. So the time is almost over. Quickly, I'll ask one question is to Dr. Muklesh and Dr. Manas before we end the session. We have a question: how do you manage the insulin-related weight gain and also hypoglycemia? Dr. Muklesh. Please unmute.
As Dr. Sahu has already mentioned, that with the advancing generations of insulins, whether we talk of the basal insulins, especially the long-acting or ultra-long-acting insulins, they have become peakless and flat. So they are the best to be used once hypoglycemia is there looming on the mind of the physician. So these ultra-long-acting insulins, whether it is U300 or Degludec, both of them, they are equivalent in terms of the profiles. They are flat, peakless, and very less amount of hypoglycemia. In fact, in practical situations, probably we don't get much of hypoglycemia, significant ones at least. Then second is, because of this factor, it becomes easy for the patient and the physician both to intensify the insulin. So it becomes safe. We can ask the person, so there can be simple algorithms, 2 units every 2 to 3 days. And it has worked very well during these COVID times. So as far as the basal is concerned, giving that power or empowering that patient to intensify, gradually increase the dose of insulin 2 units every 2 to 3 days till the fasting is nicely controlled. And then you can come back and talk to us for further addition or control of the prandial insulin. This is regarding the hypoglycemia part. If I talk of the shorter acting insulins, now we have got FIASPs, very fast acting insulins. They are near physiological and therefore they come in. That means the action onset is very quick and the action goes off with the meals. And this becomes near physiological. So you don't have that shoulder and therefore that hypoglycemia which happens postprandially is not there with the faster acting insulins which are now available with us. If we talk of weight gain, once again, the newer insulins, they lead to less of weight gain, and because that weight gain is basically because of less of hypoglycemia, so the person is not consuming to cover for that, and therefore there is minimalistic weight gain. In fact, if you want weight gain, then insulin is something which has to be used, as Dr. Barua has already mentioned, that wherever the patient is in catabolic state, like tuberculosis, then certainly this is something which has to be initiated right in the beginning so as to make the person more metabolically safe. So these are my views on the hypoglycemia and the weight gain.
Very, very
well said. I just want to say a few words or practical points. Insulin therapy comes with a lot of responsibilities, both on the part of the physician and the patient. Monitoring is the key, for which, Dr. Mukulis has already mentioned, like you have to titrate. For titration, you need to counsel the patient monitoring. And as a physician, you need to understand that what kind of drugs, other drugs you're using. Like, for example, if you're using pioglitazone, probably that's not a good choice if the patient is gaining weight. And probably you can use SGLT2 inhibitors, which can neutralize the weight gain a little bit. And you should not use excess dose of insulin. And for the patient's part, it should be counseled that insulin is not a certificate for go out and eat everything. It's just a therapy. You cannot just think that from now on I can eat everything because my problems have been taken care of by insulin. So dietary discipline is still more important, even if the patient is given insulin. So those kind of things are to be remembered and told to the patients, and the patients, physicians also should remember all those things.
Yeah. Very rightly covered. That was the last question. In fact, I was about to ask you the myths existing in our country regarding insulin and how do we dispel it. So I think that's also mostly covered. I request Professor Das